So I'm going to talk about the tic disorders, and I must acknowledge at the beginning that some of the material that I have used from IACAPAP, or International Association for Child and Adolescent Psychiatry, for some statistical analysis. I use their data. So at the beginning, I will start with what are the tics, and actually the definition of a tic. So the tic is a sudden, abrupt, fast movement comprising various muscle groups with or without vocal utterances, and they occur usually involuntarily. Tics are very brief but repetitive, not rhythmic, and usually appear in a short burst, or sometimes even they appear in a series. They may be classified according to the degree of complexity as a simple or complex tics, and also can be classified according to their quality as a motor or vocal tics. Around age 10 or 11 years, children usually begin to report a premonitory urge, and this is a sensation like tickling, itching, or prickling feeling in the area of muscles groups that are involved, and this sensation announces the imminent occurrence of tics. But as I already said, this premonitory urge is usually found in older children, not in less than 10 years. And the tics are usually, they are just part of various muscle groups if they are complex, and using the classification system of the ICD-10 or DSM-5, we can see that there is no one just tic disorders, that there are a group of several tic disorders, and I must say that more or less this is the one of the best classified neuropsychiatric disorders, since, as you can see, even in ICD-10 and DSM-4, we cannot see some big difference between these two classification systems. So, disorders, 95.1 combined vocal or Tourette syndrome, 95.2 other tic disorders, and unspecified tic disorders. So I already mentioned that the range of the tics they can be simple, and usually they are like eye blinking, grimacing, and usually they begin from the head, and they are just spreading rostrocaudal from the head, shoulders, and to the other body parts. But also they could be complex, like crouching or hopping, then copropraxia, echopraxia, or even doing self-harm, like for example, beating by themselves to the head. Vocal tics could be sounds, noises, sentences, or even words. And also the vocal tics could be simple, complex, and the complex vocal tics can be the content could be coprolalia, then echolalia and palilalia, when they actually repeat their own words. These are on the next slide. We can see the most often tics for motor and for vocal tics. And for motor tics, as you can see, it is eye blinking, rolling of the eyes, grimacing, shaking of the head, twitching of shoulders, twitching of torso and pelvis, twitching of abdomen, movements of the hands and arms, and movements of the feet and legs, while the usual vocal tics are coughing, throat clearing, sniffing, whistling, grunting, animal sounds, uttering of syllables, uttering of words, and shouting. I will try now to play the video. I don't know if it will be successful, but I will try just to play. I must make a new share with the YouTube. Can you hear?
Tourette syndrome is a certain brain defect. It's a neurological problem that I was born with that causes you to tic. Tics control our bodies, ticking, like coughing, twitching, like snapping over time, and do a lot of things people wouldn't like. Not contagious. Metal, they like come all the time. Coffee, it's there. Why do you have to make fun of it? They just think I'm real crazy. A person who has Tourette's isn't like a whole another person. Like me. I'm a regular kid. It feels weird because I'm in control of everything else. Why aren't I in control of that? Why can't I stop myself from doing that? There it is. Try to hold back too much. You can't think of anything except holding them back, and you can't think of anything except doing that. Like I didn't mean to. I just feel like kind of funny inside. I say like, why can't I stop doing this? Why can't I stop doing this? If my hand twitches really bad, I just hold it down on like a table and just take deep breaths or something and just try to make them stop. Tics like they're like it's like an itch. Like you have to like scratch it. You just do it. It's like controlling you in it, and you feel like you have to do it or else something's gonna happen. When I'm having a bad day and a lot of tics are coming out, I go really pretty much crazy. Okay, note for you. You need, before you go into school, you really need to tell people that you have Tourette's or else it's gonna be a big, big hard time for you. They called me a monster. I felt terrible. I felt like I was evil. There's a point in a friendship with someone with Tourette's where they ask, I've always wondered, can you stop it? Can you like just stop? I had a tic, like a really loud screeching noise. All the kids would like tell me to stop and just keep staring at me. Stop it. And I would say, I can't. Stand up, dust yourself off and say, you know what, this sucks, but I'm gonna have to deal with it, you know? Kids with Tourette's syndrome are just like any other kid, just with a few disabilities. But overall, we're like you.
Okay, I'm just continuing with the presentation. So just to clarify it, so the tics could be transient tics that in which the symptoms last less than 12 months, and they found mostly in school-age children, and they don't need some specific treatment, but also there are chronic tics where the tics more than 12 months. Then we we came to Tourette syndrome. The Tourette syndrome, in the Tourette syndrome, we have several motor tics and at least one vocal tic. They could be just manifested not at the same time, and almost the tics should be present almost every day, more than a year, and the onset of the Tourette syndrome is usually in children less than 18 years. It rarely occurs for the first time in the adulthood. And now here's some of the epidemiology that 4 to 12% of all children have tic disorders, 3 to 4% have chronic tic disorder, from which 1% is Tourette syndrome. And the children and adolescents have 10 times more tic disorders than the adults. The boys are 3 to 4 times more diagnosed with tic disorders than the girls. And there is some familiar predisposition for tic disorder. The worldwide prevalence is about 1%, and it's different from country to country. It depends on the classification systems in the country, medical priorities, ethnicities, and epigenetics and racial genetics. For example, in China, they just say that they have lower or maybe the lowest rate of tic disorders in the world. And there are some statistics from the USA that the Afro-Americans have the lower rate than the other population in the America. But there are also some studies that says that the tic disorders is similar, without effect of demography, family history, clinical features, treatment outcome, associated conditions that can be found in every culture in the world. The onset of the tic disorders is between 2 and 15 years, with the peak from 6 to 8 years. And as I already said, the motor tic of the face are the first tics that we could notice. Then the tics could spread to the shoulders, torso, and extremities. Usually the vocal tics could be found 2 to 4 years later than the motor tics. And this is also very important, that there are natural fluctuation in the tic severity. So every 6 to 12 weeks, they change location, complexity, type, intensity, and frequency. And this is important. Why? Because we must have this in mind when we are doing the therapy, that sometimes we could think that the therapy is working, and actually the fluctuation, as you can see now in this slide. So, for example, we start to give the therapy, and after 8 to 12 weeks, actually it is a natural fluctuation of decreasing the tic severity, and we could think that the therapy is fine, or vice versa, or opposite. Sometimes we think that the therapy is not working because maybe we are in this period when we have again just to say more difficult picture of the tic severity. In older children, they control better the tics and could make suppression minutes and hours. Actually, they do this in school, but when they come at home, they have increased intensity when after school day. Also, the worsening of the symptoms is found during the adolescence, and but there is reported remission during young adulthood. And sometimes parents are asking, should we just leave it and not give any therapy, because we think that maybe in the adulthood this will be the tics will stop. And the children and adolescents have 10 times more chance of having tics than adults. What is the prognosis? The prognosis is poorer if we have familiar history, or if some of the parents actually have the tics or had it while he was a child. Existence of vocal or complex tics are also give poor prognosis. Comorbid hyperkinetic disorder, obsessive compulsive symptoms, and aggressive behavior versus self or others is also making the prognosis more poorer. The spontaneous remission is found in 50 to 70% of the chronic simple or multiple tics. And for the Tourette syndrome, this percentage is lower, from 3 to 40%. But as always, we could not be sure when, if we will have the spontaneous remission or not. The fluctuation according to the environmental and social effects are the following. For example, the tics can decrease during distraction, high concentration job, cannabis use, alcohol use, or intentional movements. But the tics are increasing during the stress, fear, emotional trauma, social pressure, joy, and tension. The etiology, like any other, I say, like any other psychiatric disorder, we still don't know the exact etiology. So we could say that it is genetic, neurobiological, psychological, or environmental. But the science says that the dysregulation in corticostriato-thalamocortical circuits are actually the main reason for the tic disorders, and they found the deviation in dopaminergic and serotonergic system. Actually, they found increased dopamine activity in basal ganglia. This leads to deficient subcortical inhibition, and this leads to impaired autonomic control of movement. Which are the risk factors? The risk factor, all of us know actually these risk factors, that it is 50% heritability, then we have premature birth, hypoxia, low birth weight, nicotine and caffeine use during the pregnancy, and like secondary causes are tumors, poisonings, infection, head trauma, and now in these days very popular PANDAS or acquired immunodeficiency syndrome after the streptococcus infection. In the medical imaging, they found a decreased volume in the basal ganglia and corpus callosum, and deviation of glucose metabolism or lower glucose metabolism in all these anatomical brain structures. The diagnosis is made according to the medical history. Then we have the questionnaires like CBCL, child behavior checklist. Then interview, there are some scales for Tourette syndrome or global tic scale. And also we must do the physical and neurological exam and EEG. These are some differential diagnoses that are also very interesting. How is the aspect of the tic, and which disorder in the differential diagnosis we could just make a parallel of it. For example, preoccupation with tic control may give the differential diagnosis of attention problem. The repetition of the tic gives the differential diagnosis of obsessive compulsive phenomena. Then monotonous tic give the stereotypy like clinical picture, eye rolling like absence, and for example, tics during sleep will give the clinical picture similar to restless legs, epilepsy, or some parasomnia. This is also very interesting and important for the case study that I will talk later, that the comorbid disorders that are associated with tic disorders are actually especially the first three: attention deficit hyperactivity disorder in 40 to 60%, OCD in 40 to 70%, and anxiety in 25 to 40. There are also some depressive symptoms and sleeping disorders that are comorbid with tic disorders. The treatment is psychoeducation to the patient, and if the child is just to say smaller than 8 years, maybe the psychoeducation to make with caregivers and teachers. Then we also have some options for treatment that I am going to talk now. Some self-help groups that I think in our country we don't have this type of group. Also, I must say that these are CBT techniques that could be used in the psychotherapy, and I must say also, we will discuss this later in the case study, that we don't actually have somebody who will do CBT with children, especially with small children in the meaning of the clinical picture of tics. I here also will say that contingency management will also have a good work, relaxation training, exposure response prevention, and maybe family therapy at the end. And I also came to another wound in our society, the medications and the access to medication. So I must say that the medication treatment is for all of tic disorders is off-label, so we don't have some special medication that is given only for tics. So we use the other psychotropic substances as off-label, just in stopping tics or preventing tics. So we must say that with all these medications, we must start slowly. And it is very important that they should be given at least 1 year. And before giving any drug, any medication, we must do several laboratory examinations and EEG, like as well as neurological exam before starting the medications. These are some of the medications that are given according to the medicine-based, evidence-based medicine. And also we will discuss later on the case study. We don't have the first one in the first two actually in our country. Then haloperidol is actually the golden standard for tics, but because of it is a antipsychotic, most of the parents refuse to give it to children. In the same group are, but maybe lighter, just to say, risperidone and aripiprazole, that we have it here in Macedonia, and I think this the last one, sulpirit and thioprid, we also don't have it in Macedonia, but they are now at the moment in the Germany the #1 medications given for tics. Also, I want to discuss with Sarah and Valerie about using the psychostimulants, because tics are for example, psychostimulants during tic disorders, even if it is not methylphenidate, that atomoxetine could be given, and especially for the children that have, besides tic disorders, emotional disorders, that some antidepressants and antipsychotics also could be given. There is anecdotal evidence that physical exercise or recreational activities in general that are prescribed could give any results, or we could say that there is no evidence for that any diet, vitamin or mineral supplementation or hypnosis have some result in treating the tic disorders. And I think here I will stop with the didactics